in the chat at the very end. We will have a Q&A session, and any questions that don't get answered, we will route to our two presenters to respond written, and then we will release those responses. If you do have any other technical difficulties, please feel free to message me directly. I will be trying to run some interference in the background. And again, thank you so much to our two presenters for sticking with us and for everyone for making the jump from Teams to Zoom.
Yeah, thank you so much for everyone being here, and sorry for the technical difficulties. Just going to say we're both in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health, but let's dive in since we're starting a little late here. So quickly, just an overview of the presentation. We're going to talk about contributing factors of why women are underrepresented in HIV research, barriers that we've experienced, and some examples of barriers to recruitment, and then Tahilin is going to give a case study on a study she's conducting in the Dominican Republic, and then we'll end with strategies to improve representation in research. So some of the factors that contribute to this underrepresentation, low perceived risk, limited awareness, and this could be of HIV or ARVs or PrEP, structural and social barriers, and inadequate funding. And I'll dive into these a little bit more. And so for low perceived risk, some people are just unaware that HIV rates are high among different communities and sub-communities. And sometimes when doing work, and I say I do, HIV prevention research and work, some people, and these are participants, they're like, that's still a thing. And we're still hearing that today. There's also this kind of like low perceived risk where like I'm not at risk, but my friend is. And so it's just others are at risk, but it's not going to happen to me kind of thing. And we still see a lot of HIV related stigma. Some people still just say, oh, I just gay men get that. And so I'm not at risk because I'm not a gay man, or engaging in sex work and the stigma around sex work and HIV together. And so just a couple examples here from some of my work. So this study was qualitative, longitudinal in Milwaukee, and I interviewed people 4 times across 6 months, and this was looking at PrEP, but I just wanted to show this example of just kind of this low perceived risk where this participant had multiple sex partners and also was not using condoms during sex with any of her partners. And in both interviews 1 and 2, when asking about interest in PrEP, she just really wasn't sure. She was really on the fence at this time. And then by the end, she actually was telling her friends that, oh, you need PrEP because, you engage in high risk behavior. And whereas she did not perceive herself. We see a lot of structural and social barriers. Lack of childcare is a huge one. And we see this come up a lot. Even in some of my studies, I try to give money for childcare so people can either, pay a sitter or something along those lines. But still, it's still a barrier, even with, trying to do things like that. Transportation, and there's our public transportation system in the U.S. is very, very poor. In a lot of cities. And then once we talk about going outside of cities or in rural areas, it's even worse. A lot of people can't miss work or, lose that income, even if we're compensating them very well. It's still a big barrier for that. Also, just not having basic needs. If you don't have your basic needs met, like housing and food and things like that, you're not going to engage in a research study. Also, the distrust and mistrust of institutions, medical institutions, just all of the mistreatment and historical, medical racism that we're still seeing today, things like that, and then also domestic violence, intimate partner violence, sexual violence. I was recruiting in a clinic once, and this woman was interested in coming over to learn more about the study and possibly sign up. And her partner grabbed her arm and escorted her out, would not even let her talk to us. So here's this is again in an example with from Milwaukee. This participant, this again was about a prep appointment that she missed, and the WIC office was right next to the prep clinic, and so she had an appointment at WIC and had to bring her children because it was going to be a long appointment, and she was going to go to prep afterwards. Well, when I asked her what would have made it easier to attend the prep appointment, she said not having these nagging kids around. It's how I forgot the last time. And then, she needs reminders, and then she just needs somebody to watch her kids. And she said, I shouldn't have made the prep appointment when I was going to WIC, even though she thought it was going to be easier for her. But this also, I think, highlights for people who are experiencing poverty and low SES and things like that. They have the things that they have to go through, the WIC appointments, doing all of these extra things to prove what their needs are. That's a huge barrier. And then what do you do when you have kids and work and other things, conflicting priorities? And of course, inadequate funding is always huge. So the amount of grant like monies awarded, those have not increased. Those have been the same, even though we've seen significant inflation over the past decades. Cost of living has increased exponentially, and so we need to compensate participants, community partners, all of that appropriately. So we're actually doing more research with less money, and that is very difficult. An example is I was one of the few people who received an R34, but the call was specifically strengthening HIV prevention efforts for women in the southern U.S. This came out several years ago. They awarded 10 grants total, and it was never intended to be renewed. So this shows like, okay, so there was some interest in let's do research in this, but we're not going to see that call or a call like that again. And also we have some clinical trial issues. For example, we have a lot of different PrEP options right now. There's pills, there's injections, there's, differences in when you can take the pills. Like, we have a lot of options right now. But one of the problems is Descovy is not available for anybody born female, because why? They, they weren't included in the clinical trials. And so not to say that, it's not FDA approved. So it's not that they can't get them, but so that kind of just, not including them in clinical trials, not including women is definitely a huge issue. So, I'm going to kind of gloss over this just for the sake of time. I will say, at least personally, and talking to a lot of my colleagues and things, recruitment has changed since COVID. It was a lot easier to recruit prior to COVID. It didn't take quite as long. There was a lot more, I think there was a lot more trust. So snowball sampling was a lot easier, people getting their friends to sign up and things like that. So it's even, boots on the ground, going into communities post-COVID has definitely been an issue. We're also seeing like more bots and scams, and it's crazy. Even if you do all of the Qualtrics, the recaption, all the things, the put in what's 2 + 5 and all of that, you still get hundreds, sometimes even thousands of bots filling things out. And more recently, we're seeing AI and people using AI to complete surveys and things like that. And so recruiting online is definitely a huge issue. So going into the community really is kind of what we need to do. But in order to do that, trust is absolutely essential. And because of that distrust of institutions,
All right.
can we, here, I'm just going to mute. There we go. And so it's so important to have that trust with and work with community partners and really be a partner in the community. And so with that, I'm going to turn it over to Tahilin, and she's going to talk about a case study with or do a talk about a case study in the Dominican Republic. So I will take it hand it over to you.
Great. Thank you, Liesl. Again, my name is Tahilin Sanchez Karver, she, her, ella pronouns. And I wanted to talk to you guys a little bit about one particular study where we have also experienced some of the challenges of involving women in our work. And I thought we could walk through it together, as well as giving you a little bit of a scope of the preliminary findings that we have. So this study is called Preparándonos Juntas. It's a study focusing on advancing PrEP for Latina women in the Dominican Republic. And these are women in particular who engage in sex work. Can we go to the next slide? Thank you. And just before I get started, I feel like this slide always comes at the end, and I just wanted to make sure it's at the forefront because without this group, Lisa sort of ended on trust being essential in being able to recruit women into research. And without this team that you see in front of you, we wouldn't have been able to do this, the work that we do. So the team from IDCP, Dra. JC Donestor, Joyces Gomez, Marta Mencia, Dariel Batista. We also have a really wonderful team at JHU, Maria Camila, Diana, Andrea, Beatriz, and Isabela, who is actually a Share scholar. And I believe Share may be present in today's meeting. So it's really wonderful to really collaborate with all of these individuals in the work that we do. We could go ahead and go to the next slide if that's okay. So one of the reasons I wanted to bring this particular study is because I thought it could serve as a really nice example for us to take a deeper dive into all of these different issues. So we know that globally, cisgender women who engage in sex work are among the most vulnerable populations in terms of their disproportionate risk and burden for acquiring HIV. This trend is also within the Dominican Republic. It's where we also see this. Women who engage in sex work are nearly 5 times more likely to be living with HIV compared to other adults. However, as Liesl sort of mentioned earlier on in her presentation, a lot of the program efforts for HIV in general, but also in PrEP in particular, which is our topic of discussion, has been aimed primarily at men who have sex with men and transgender women, which often it's limiting opportunities for the involvement of cisgender women in our studies, and in particular, in this case, cisgender women who engage in sex work. Can we go to the next slide? So this particular work that we did center around 2 study aims. One was to examine the current provision of PrEP services within a diverse group of health facilities in Santo Domingo and be able to map the process or pathway of female sex workers are they entering these spaces. And 2 was to explore the feasibility and acceptability of establishing a multi-level PrEP navigation and support program for women in health facilities that are offering PrEP services. And we did this through 2 sets of aims. So for aim 1, we employ value stream mapping. For aim 2, we really focus on conducting in-depth interviews with women on PrEP, women not on PrEP, as well as healthcare providers. And what I'm talking to you about today is a little bit more on the information that we gather from the in-depth interviews. And this is preliminary. Our study's ongoing, and we are actually we're getting really close to wrapping up the study for this particular research program. Next slide. Okay, so I wanted to spend some time here because our study, we did experience some difficulties in engaging women in our HIV research. And I thought that this will also be really important in today's discussion. So first and foremost, a lot of this is something that Liesl has mentioned and just kind of magnifying it a little bit here. So there were funding related challenges. So in the Dominican Republic, and in particular in Santo Domingo, there was a reduced financial resources that was often limiting the capacity for healthcare providers to be involved within the PrEP sort of access and delivery. This also involved reducing the reduction of peer navigators, decreased availability to provide comprehensive and multidisciplinary support for women. So when we were going into the clinics, we started and to be and also to sort of be mindful for, our study was, we're still wrapping up the study. So during the time where there was a lot of federal grants that were being impacted by the new executive orders, we sort of witnessed that within our landscape in Santo Domingo, Dominican Republic. So what this did was it created recruitment a lot more challenging because we do value a lot. There's a lot of trust that needs to be built into how we are working with women, how we are recruiting women. So when you are reducing the workforce within the healthcare environment, those are often the individuals that we're working with in order to facilitate the recruitment process for our research, for the work that we do, and also when we're thinking as well as sustainability efforts, right? After the research is done, how can we make this more sustainable and like make it to so it's implemented? And just to kind of give you an example, in one of the particular clinics that we were working with, they reduced their mental health services to only one psychologist on staff to take care of their entire clinic. And this really does limit access for women at risk for HIV. In when providers explain to us that they really rely on having these very integrated tailor approaches in order to reach women, and to be able to allow them to have access on PrEP. They do group sessions with women. They also do family-based interventions. They also do operativos or community outreach campaigns. And all of this was drastically impacted by the funding related challenges. So in all, there is this really strong effort to understand that women who are facing social and structural vulnerabilities, we do need targeted approaches. And all of that was very much it was limited drastically through a lot of the funding challenges that were sort of trickling down from many of the grants and also many of the operations that were happening in Santo Domingo. We could go to the next slide. And here I have a quote from a psychologist, and this psychologist is sort of talking about women who engage in sex work and really letting us know that this is a group that is often coming with very low socioeconomic resources. It is difficult for them to come to the clinics. It is difficult for them to like be able to go to their appointments. And you really do have to work with families, and they're sort of expressing how research like this is really important. So, and kind of letting us know how they've been affected by the reduction of funds. So I wanted to kind of move into some of like our preliminary findings because it does sort of take us through why we want to be inclusive of women in HIV research, but also some of the impediments or barriers that we have faced, as well as some of the opportunities. I wanted us to end on a good positive note, like to kind of like move the research forward and how do we continue to do the work that we do. So I'm walking you through four preliminary key findings that we have. So let's start with the role of healthcare provider access and peer navigators as well. So sorry, I'm trying to, perfect. So similar, all of this is very similar to what Liesl mentioned. I'm just giving you more data on this. So providers, they felt that there was a severe knowledge gap among women, in particular as it relates to PrEP, right? So providers constantly highlighted that women have very low awareness of PrEP compared to other populations. And then on top of that, you're also dealing with stigma, right? So stigma is going to shape engagement. So providers often mention how because chapeo or transactional relationships are not necessarily social, and I think we might have lost Lisa. Can you guys still see slides or no?
Hope she's back.
No,
Oh,
no
there you
slides.
Okay.
We
Let
we
me
did lose the slides.
Liesl,
I
can you
could
reshare the
I
slides?
could do it actually. I just pulled them up so I could do them really quick. Um
To add to the
Sorry
technical
everyone.
issues today.
No,
Sorry.
that's okay. It is not our day today.
No,
Two women talking about research. Who knew? But we're gonna do it
you
better.
you got the slides. You don't need me to.
I have them. Perfect. Okay. All right, so I was sort of like telling you a little bit about some of the preliminary findings, and the reason why I wanted to go over these slides was because I do think it offers some opportunities for, or at least discourse or conversation to happen of why we do need to have women involved in HIV research, but also what are some of the challenges that are happening on the ground, but areas of opportunities to move the work forward. So let's go ahead and start with preliminary findings related to the role of healthcare access and peer navigators in accessing PrEP. And I mentioned already how providers were constantly highlighting that women have very low awareness of PrEP compared to other adults, other populations. And something that was really important in our particular study is that they also mentioned how stigma is really shaping engagement. So because of CHAPEO or transactional relationships or sex work is more socially accepted than sex work, it often leads to, there's sort of this misclassification of risk in lower healthcare engagement. And it has to do a little bit around maybe women not wanting to disclose they're engaging in sex work, or perhaps not wanting to disclose that they're engaging in these transactional relationships. So really stigma around sex work or transactional relationship is really shaping how they are engaging with providers. And then, of course, it's going to shape how providers are facilitating all of these conversations around PrEP or HIV prevention. So no surprisingly, it's going to lead to lower PrEP uptake amongst female sex workers compared to other populations. And this is really important in our context in the Dominican Republic because services are often available and free. I say often because we have seen in the past that there has been some barriers in accessing these services, but they're meant to be available and they're meant to be free. So there's really a need for targeted dissemination strategy through different communication channels and social spaces where women are often interacting. So here we have a provider who is talking about this particular issue. So our interviewer asked, how are your conversations around PrEP happening? And the person said they're surprised. They tell me, what? How come? How is it? There's a medication that could help me prevent HIV. Really? Can you tell me more about it? So really, there's this idea that they're coming into these conversations having no knowledge around PrEP or PEP. So something really important is wanting to make sure, like, how can we sort of close that gap in terms of knowledge and information around PrEP? To that end, some providers talked a little bit more about providers and women. They talked more about peer navigation as a strategy to improve PrEP access for women. So our findings highlighted that peer navigation or peer-based strategies are a key mechanism for bridging access gap and fostering trust. Again, we need that trust in order to be able to engage with women, to do work for women, with women. So we really need to be building on to that. And they emphasize that there is a need for peer-led navigation programs or those peer-based strategies to improve PrEP engagement and retention among women. And here we have one participant, and this person is basically talking about they feel like this navigator will be a person that wouldn't discriminate them, that they will be able to talk with a greater degree of trust, and they will be able to let them know, look them in the eye and let them know exactly what's happening to them. And they often, when we talked about like sort of that peer navigation or that peer-based approach, it was often someone who had shared lived experiences as women themselves. And then something else that I wanted to highlight, because it is a little bit different from what Liesl mentioned, is that while we do know that low perceived risk for HIV is a key factor contributing to that underrepresentation of women in HIV research overall, in our study, we're actually seeing the other side of the coin. So our women in our study, they're very aware of their level of risk, their level of HIV risk. And this often is leading to having a desire to have more information around PrEP for those who are not on PrEP. So here we have one person who is basically saying, because of my work, I am much more exposed. So I need to be, so therefore I need to be more responsible. So we are seeing sort of this level of desire or enthusiasm around wanting to learn around PrEP. I think what happens often is that, similar to what I mentioned, because sex work in this particular case is stigmatized, perhaps those conversations with providers are not happening as often in terms of like thinking about risk and thinking about the availability of resources like PrEP. Other structural and interpersonal barriers to condom use also driving PrEP uptake. Here we saw that women are basically explaining that they have limitations to their ability to engage in condom negotiation with their clients. So really PrEP becomes this much more reliable form of protection for them. And here we have one woman who sort of mentions how men don't want to use condoms. So really having that will be a motivation in itself for wanting to get on PrEP, wanting to use PrEP, is that you'll have a lot more of that agency to be able to take care of your health. And continuing on this theme, they didn't really women express not wanting to rely on clients. They really wanted to, and PrEP often became this topic of conversation that allowed them to talk a little bit more about control, about agency, safety, and reassurance. Here we have one particular participant who said, if I were on PrEP, I would feel like a hitman. I would feel like nobody's going to go ahead and kill me. No one's going to get me sick. No one is going to get rid of me. So really having this sense of like strong agency and being able to control their own health. And again, another person talking about how this will be like their backup and being able to like rely on PrEP as a way to protect themselves. And then lastly, wanting to, there are implications for this work. And one of the reasons I highlighted is because I also wanted us to end on a good note if we kind of want to take like the work forward and continue our focus on women in HIV. We need to work on improving PrEP awareness and healthcare system engagement. So really addressing those knowledge gaps that Liesl mentioned, as well as in a note, Liesl also talked about risk perception, but we really need to sort of bring women and have them be part of that conversation more actively and meaningful. So many participants, as we saw from this particular brief scope of the study, we saw that there is a lack of awareness around PrEP, but not necessarily a lack of desire of wanting to engage with PrEP. So how can we create better tailored programs for this particular key population? Also, there is a need to strengthen provider-initiated education and clear pathways for PrEP initiation and continuation. So we know that providers, at least the providers that we spoke to, they are very aware that there is stigma around sex work or stigma to like talk about PrEP for women who engage in sex work. So how can we normalize the conversation around PrEP use for women, right? Because it should be available to all, right? It's not something that necessarily should be a conversation that we have to sort of like be so strategic about, like really how can we have like those conversations much more openly? Because as we saw from our study, not everyone is going to share their risk factors. Not everyone is going to be sharing their occupation. So how can we normalize the conversation and make sure that women are very much central and a part of that conversation? And then also, we think that there are opportunities for streamlining access and initiation practices around PrEP. We know that there's other scientists, other scholars, community partners working on shared decision-making tools. And we do think that this could be something that could be applicable in this particular work area. And then finally, continuing to position peer-based approaches as effective program for having these conversations around PrEP, or to like really programs for accessing and engaging in PrEP. Our projects have really shed light to peer navigators as being cultural brokers between community and fragmented health systems. So how can we leverage those peer-based programs, because they're building trust, they're reducing stigma, and they're increasing uptake in a way that will facilitate better engagement and conversations around HIV prevention, and in particular, in this case, PrEP. And with that, I don't know if Liesl, you are with us? Okay. So we wanted to just end with some strategies, and I apologize if we're going quickly. I know that we're short on time, but some strategies to improve representation. And I'll go ahead and let Liesl take the mic.
Yeah, so I mean, first and foremost, we really need to have increased funding. And one is just, I mean, right now, especially, there's just not a lot of funding available to even apply for doing research with HIV and women. But just in general, even aside from that, we need funding that is reflective of the cost of living, and to be able to engage with community partners and properly compensate or provide childcare, all these other things that will help increase participation and representation. requires more money. And so the funders also need to understand the community needs. And part of that is how long things take, so you're cramming these very large things into a very short period of time. And so really being able to say, okay, it's going to take me this long to further expand my relationship with the community partners and really get embedded. And so I'm seen as a trusted person or things like that. And so it doesn't happen overnight, and that takes time. And regardless of funder, whether it's government or foundation, that's not often reflected, which often leads to no cost extensions. But the no cost is also an issue there. Um, Obviously, this trust and developing and strengthening community partnerships that you already have is really, really key, especially with the kind of difficulties that we can run into when doing online recruitment. Even if you're doing in-person studies, recruiting online can lead to some issues. So as Tahilin mentioned, that peer navigation or the community health workers are really key. One of my studies, I was asking participants, like, what would you like to see in a program that would, help improve prep, and so they were like, a lot of them were, I want to hear from a Black woman on prep. And so they want to see somebody that's doing this, and that will also help increase representation in the research. They're going to be more inclined to do this and to want to participate in something where they can hear straight from the person that's experiencing it. And then lastly, those social services, it's so key, whatever childcare, transportation, but even, having other access to other things, other social services, such as, you know, uh, jobs, helping somebody, maybe do resume writing and things that might not seem related to HIV research are very, very, very relevant, because for prevention, just in general, or any type of public health intervention, the more you intervene at the structural level, at the poverty and all the, housing and things like that, we're going to see other things improve. And I'll see if, Tahilin, do you have anything to add to any of that?
No, I think that I mean, I feel like you highlighted everything nicely. I just want to say that improving representation, to me, it also means going hand in hand with communities and even having like making sure that there's a lot of co-development happening from the onset, because then you'll be able to better strategize on what are going to be the different strategies that will work better for the sort of like the recruitment of different community members, but also when you're thinking of sustainability. So just highlighting that often when you are sort of like going into the ideation of a project together and like the co-development, co-creation, then you're able to sort of really think through a little bit more around all of these different points and like troubleshoot some of the different solutions. And just kind of like hold that community as sort of like expert front and center of the work that you do.
Absolutely. Yeah. Rather than the approach that we see often where it's like, oh, let me develop all the methodologies and the interview guys, and then I'll just get, the community advisory board will just give me feedback. And it's like, no, that needs to be co-developed. It's a partnership. So yeah, that's a great point. Thank you. And with that, I think that was other than our slides with our emails on it for the next one. I think
Oh,
that's it.
excuse me. Sorry.
With that, I think we did a pretty good job getting through, given all the technical difficulties. I mean, we had to rush it a little bit, but oh, and feel free to reach out to us. So
Wow, you both did great. I couldn't even tell you were rushing. So thank you both for sticking through. You did fantastic. We do have one question about the content here in the chat from Jerissa Greenard. It says, how does Chipeo, or what may be described as transactional relationship, differ from sex work? Are there specific relational, cultural, or financial components that distinguish the two, or is this distinction partly shaped by moral judgments that make one seem more socially acceptable than the other?
Yeah, Andresa, it's a really great question, and one that we have been sort of grappling a little bit more around, like language and terminology. And the way that what I'll describe is from sort of the access of services component. What we were noticing is that depending on the language being used, one may be more socially, like more morally, socially acceptable than the other. So the reason we brought it up was because there we're noticing that there is a lack of wanting to disclose like occupation or activities to healthcare providers, and then for providers to then be able to have that conversation around PrEP. So what we notice is that women who are often, where at least women in our study sample, depending on how they express their sex work occupation to others, it sort of limited what type of information they were receiving from providers. So if they felt like it was going to be highly stigmatized, they wouldn't release that information at all, or they would, or some women would. In other studies that we have focused with female sex workers, we have gotten women who have told us, I will never tell them my occupation because then they'll sort of start focusing from the waist down. So I won't be able to get that whole person care that I need. So what we're noticing from this study is similar trends. And the reason why we brought up chapeo versus trabajo sexual is because the providers themselves were telling us that they were kind of getting that they're sort of getting this different type of conversations around it, and then that could have different different outputs in the conversation around risk exposure and in what are some of the preventive methods like PrEP, for example. So one of the implications that we have in our study is like, well, then just normalize the conversation. Why does the conversation need to sort of start from sort of the occupation or the activity? What is there a way to just have the conversation and present it in a way that women won't feel like if they are giving too much of like information around themselves, like they will be stigmatized? Is there a way to just normalize the conversation and make it very open and engaging with everyone? So that's what that sort of relate back to. Jerry said, did that answer the question? I see.
Yes, thank you so much for the clarification. I really appreciate it.
Hi, my name is Michelle Lopez. I had my hand up and I really would like to engage in asking a question.
Hi, Michelle. Yeah, welcome.
Thank you. I've been listening at this. First, I want to thank you. A great presentation. I am a community engagement coordinator with Albert Einstein, and I do a lot of interactive work, with the community, bringing members to be advisors to the researchers. But I'm a peer, and I'm a peer on the side of I am a woman living with HIV for the last 36 years. And one of the things that I have seen very effective, I did see that you guys use peers, and I just wanted to know what has been the outcome looking at one are the peers, individuals who has been paid to be a partner, because I look at peers as being boots on the ground. And when you have a population who's living with HIV, who is engaged in methods of advocacy, you can then work with this population to develop strategies. And the strategies looking at, here I am living with HIV, these has been my experiences, but however, not but, the however, I would like to be part of helping you prevent yourself from getting HIV. I have seen that very effective, and I have seen also too other entities that can provide funding to help those peers be able to carry out, the methods that they have developed with you, and it's a great impact to research. So
Oh no, she just cut out at the very. Oh, Okay.
I was giving it a second to see if it.
Well,
Strategic
there,
method
Michelle,
that
you just cut out at the very end. Can you just say that last part a little, real quick?
yes, I said do not just look at peers, as, the boots on the ground, but the boots on the ground can also too work with you to develop
Mhm.
strategies.
Yeah.
Yep.
Yeah. Well, oh, I think she cut out again.
Many of us are aware who are the sex workers, and all those great things.
Yeah. Um, well, first of all, thank you for the work that you're doing.
Mhm.
That's so amazing and so important. And yeah, I mean, Tylene, do you want to speak to how you're engaging with your peers?
Yeah. Well, so first, I will kind of share a little bit that our team, you bring up a lot of different, really important key considerations on peer-based approaches or peer navigation. Who gets paid? Who doesn't? What makes a person a peer, right? What role do they have? And to that end, one thing that our team did and is doing very strategically is we're doing a scoping review on peer-based strategies, in particular for the Latino communities. Because one thing that we wanted to do is to be able to highlight what are sort of the peer roles, what makes a person a peer, how are they remunerated? Like how are they paid? Are they in volunteer basis? Are they getting paid? Are they like really embedded into a system? And then also what we told our community partners, and this is something that came at the request of our community partners, they really wanted to know what are the key ingredients for an effective peer navigation strategy. So this is something that our team is hoping to continue to work on and to answer, and we're hoping to be able to have that document accessible for everyone hopefully in the coming month, actually. But in our end, for this particular study, we do at least in the work that we do in the Dominican Republic. So I have there's two other projects that I also work with, sort of built working on this like peer-based strategy and approach. But what we know from the work that we have here in the Dominican Republic, as you saw from one of the quotes, is that there is a reliance on peer-based approaches or peer navigators, and there is a need to continue to engage with them and an understanding that they are not a supplemental part of care, but an integral part of care. I think what we notice, at least in this work, is what you saw from like that slide that I showcased, where it sort of talked a little bit around funding challenges. And as you notice in that sort of segment, one of the funding challenges that happened was that there was a reduction in workforce, which also impacted peer-based strategies. What we know is that peer-based strategies are operating differently. So there are clinics that may have peer navigators that are part of their clinic environment, others that may be peer navigators that are affiliated with other like research studies, for example, or project-based that are peer navigators. And I think one of the main priorities in our team is to sort of really work a little bit more through an implementation science lens to think about more of the sustainability of effective peer navigation strategies, because we know, at least in the Latino community, they are incredibly powerful in promoting health and well-being and linking individuals to very complex and fragmented healthcare systems. And we need them, and they're very oftentimes they're the ones bringing culturally and linguistically congruent information to our clients or patients. So we are coming from the lens of what an asset they are to our communities and how we navigate like toward the HIV care continuum. What we're trying to uncover, though, Michelle, goes back to your question in terms of like how are peer navigators being integrated, and how are they sort of like operating on the ground? Because what we are seeing that there is a myriad of way of how they're working. So some peer navigators are, who are even peer navigators for HIV, for example, they may be working on legal services for their clients or going to school with their clients. Like maybe there's like a school issue, they'll go to the school with them. So we know that their roles oftentimes are occupying spaces that extend beyond sort of like the healthcare particular component. So what we want to do is we want to also be able to further assess that more. And also from a trauma-informed place as well. So when does the peer role become too excessive? Like, like why do they have to assume every task? So that's work that it's ongoing. But our team is definitely coming in, Michelle, similar to what you mentioned, is that we're coming in with the respect and the knowledge that they're integral part. They're not a supplement. It's not like a supplementary.
Exactly.
Yeah, they're integral to really achieving optimal like health outcomes. And how can we continue to like shed light on that, magnify, amplify their spaces so there is a lot more buy-in for sustainability of efforts for peer-based strategies.
Lastly, I have to say, please acknowledge peers as a culture that
Yep,
is needed. The culture is the
I love that.
intervention here that can impact the outcomes of your studies and your research. That's
I
so
love, thank you.
Yeah,
Yeah,
hugely.
absolutely.
Well, and I will say, like, so in the American Public Health Association, there was like a caucus for community health workers, and from there they actually created a national association.
Mhm.
So there's literally the National Association of Community Health Workers, and so it's a place where CHWs can get together, and we're starting to see more advocacy of like, no, we need to get properly paid. We need all of, and all of these things. And actually, there's even been studies of like the CHWs not being able to be the best because they don't have their basic needs met. And so
Mhm.
like they need, they might need some help with that too in order to, further recruitment. So yeah, it's a lot. I'm so glad you brought that up, Michelle. Oh, I thought,
El
oh,
Magada, I see your
yeah.
question in the chat, but I also saw your hand. If you want to come off
Mhm.
mute and ask your question, feel free to do so, or else I can read out the chat.
Okay, thank you very much, Tahilin, for a comprehensive presentation. I had put my question in the chat, however, I can continue to ask it.
Yeah.
You highlighted that there was evidence of low PrEP uptake among cisgender women. So did your study get an interest to investigate into the social-cultural factors that influence the low PrEP intake amongst this population? If so,
Yeah.
how did the study, overcome this?
Yeah, we did. So we did. As part of our sampling approach, we also included women who are on PrEP to try to understand like PrEP interruptions, but also because we were interested in PrEP persistence. So being able to get back on PrEP if they wanted to, if they ever wanted to decide to stop PrEP and then go back to it. I will share that we just closed off our value stream mapping and ended our interviews. So our team is analyzing a lot of the data, which is why I mentioned that is a preliminary finding. What I could share a little bit on is that oftentimes lack of uptake wasn't necessarily on not wanting to be on PrEP, but it was just not knowing how to access PrEP or just not really being able to like navigate the system. So for a lot of the women that were not on PrEP, for example, we in during our work we would explain to them what PrEP was and because they wanted to know more information, and often we were linking them to our local teams in Santo Domingo to like be able to manage those considerations if they wanted to take on PrEP. One of the clinic sites that we did for value stream mapping, for example, they had momentarily stopped some of their PrEP programming because of lack of funding. And then when our project kicked up again, it was sort of it was sort of coincidence that they were able to sort of like get back on it. Facilitate PrEP. It wasn't our project. I just want to make sure like we're clear. It wasn't my project that sort of kick up like the PrEP axis again. It was coincidence. But so what we notice is that there is enthusiasm oftentimes, but there's just a lack of PrEP availability. Oftentimes they're still working under oral PrEP, so they don't injectable methods. We didn't have anyone tell us that they're on an injectable long-acting PrEP. And then some of the barriers that we want to take take a look at a little bit more are discontinuation. So individuals who like stop PrEP, but so far we haven't. I don't want to misinform you and give you the wrong data because we are like sort of deep in analysis. But the one that's really salient is just not knowing where to go or not wanting to go to an HIV clinic because then they feel like that people will then think that they have HIV. So that could have consequences for client loss. So if they think that they have HIV, maybe some of their clients won't come to them anymore. So yeah, so it was a little, some of those are the two sort of arms that I could tell you a little bit more about.
I had very similar results in the US in Milwaukee and in Texas, where it was like some people were literally mad that they didn't know about PrEP because they're like, I wish I knew about this like a long time ago. And so a lot of it is it's not lack of interest, it's other stuff.
Yeah.
Yeah.
Yeah, and in our site, because the PrEP services were often embedded within HIV clinics, it was also like lack of desire to want to go to HIV clinic because then they, and that's also internalized stigma as well, I'm sure. So, did that answer the question? I just want to make sure. Um, I think it was El Magada.
Yeah, sure. Thank you
And I
so
will
much.
put my email on the chat in case you want to chat a bit more because we just had a meeting on analysis prior to this meeting. So I'm happy to report that we're moving through that.
Okay, thank you.
I will have mine too, but I think we're at time.
Yes, we are at time. Dr. Sanchez Carver, I know you mentioned you have to jet. Liesl, I don't know if you have a little bit of time. There's one last question about what does community look like, and how is community an element to implementation science? And are we implementing a top-down approach, or are people living with HIV driving implementation science? I don't know if you want
Oh,
to respond to that, but I don't want to hold Dr. Sanchez Carver hostage here if you have to roll out. I do just want to say again, thank you so much. I think this technical difficulties is very representative of the field of HIV and HIV research, HIV community. Lots of curveballs being thrown at everyone, but just like the community is doing in real life, you guys persevered and you pulled through and did an amazing job. So thank you both for that. And I wanted to make sure I said that before you leave, if you are listening. Well, thank you both.
yeah. Yeah. Are you you're taking off, Tahilin?
I unfortunately did, but I just wanted to thank everyone for joining this space. And it's such a great question. Shakit, probably mispronouncing the name, so I'm just going to say Rose, but it's a really great question. And what I would like to just say, really, a bit of information is that, yes, I do. I think in the work that I do, it would be wonderful, right, if community members knocked on my door and were like, "This is an issue we have, and this is we want you to help like address it in this way." But oftentimes the sort of the what it looks like, it's sort of we're kind of coming together and that part I think that there's more work like that's we would strive for the knocking on the door where they're really coming to us. But oftentimes it's a lot of like the co-development happening. I do have to jump off, but I know Liesl will provide a fabulous answer. Thank you, everyone.
Thank you.
I don't know about fabulous. It's a very I mean we could have an entire day talking about this. But no, I think I think historically it has been top down and I think it still is and I think there's a few people who are saying that it shouldn't be top down. But I think the other issue is that we as researchers have been defining community and not letting communities define what the community is. And, and people, we also have to take this, intersectional lens of like people are part of many communities. And so I think that's part of working, why it's so important to work with and collaborate with communities from the get-go rather than coming in and just asking for feedback. Yeah, go ahead.
Thank you both for your responses. I just came off last week. There was an incredible conversation specifically around implementation science with the choice agenda. And that was a bit of our icebreaker, if you like.
Oh,
That's how we
yeah.
started off the webinar. And so you're absolutely right that it's for 40 years been top driven, you know. Like one of the other presenters, I'm a person living with HIV, 41 plus years. And so why are we continuing to replicate a model that is actually a part of the problem and not the solution?
Right.
Without people living with HIV driving this implementation science,
Yeah.
how are people on the front line, people in the community that are meeting people where they're at?
Yeah.
It's gonna, I'm not optimistic.
Yeah, I hear you, and it's unfortunately, well, I will say I think the new generation of researchers do have this perspective, but historically the ones that are getting all the funding and all of that are tend to be the top-down approach. So I think we are going to see a shift. It just, it should have happened a long time ago, or should have never been there in the first place.
We need one now, not next year, not the year
100%.
after, not 5 years,
100%.
not 10 years. If we have a golden opportunity to really kind of advocate, and it's people like you and all the other presenters on the call that have the opportunity to create that change.
100%. Yeah,
We can all do
absolutely.
this together, but it really takes people like you to stand up and say, we've been doing this for a while and we haven't had the outcomes we are looking for, and we keep redoing it. Let's
Yeah,
listen to the people on the ground.
absolutely. And we need to have these kinds of conversations just like this to be able to do that. And so, then I can go back to my department or the school and be like, hey, this is what I'm going to do, or, and that's, you just got to start that conversation. Absolutely. And, uh, and do, and actually do it, and demonstrate that for everybody else. So somebody's got to start it somewhere, and then the other researchers will hopefully jump on.
There will be more
Thank
people
you,
that will
Shakina.
jump on to this implementation science if we actually
Absolutely.
can actually negate that.
Yes.
Yes.
Yeah.
Yep.
Maybe we can work
Absolutely.
together with you or myself, Shakina, and any other of the community folks, who are involved in this wavelength. Let's plan a webinar on this.
I love it.
Let's start.
I would
I
love that,
abs-
Michelle.
We know the need is there, so let's just
yeah.
demonstrate, give people some suggestions and solutions, because some of us are already engaged. And thank you, Shakina, for pointing out the
Yeah.
scientific implementation and the need for community taking the lead. It's there, so let's just do it. Thank you.
Michelle, I put my email in the chat.
Nice. Thank you.
I'd love to connect with you, Michelle.
Absolutely. Let's do it. I would definitely be reaching out to you. Thank you.
Making connect. This is fantastic. Like, I think one of the NIH, it was the National Institute of Nursing Research or something like that. They put on a 1 or 2 day conference on engaging community health workers and, nursing in HIV prevention and care. And so I went, and one of my friends who actually started the CHW National Association, he's a community health worker. And so I went to see. There was only one session presented by community health workers, and he was the only one that presented. Everything else was academics, clinicians, like all of this. And I'm like, wait, but why are clinicians talking about how engage, using CHWs to gauge, like, why aren't we hearing from them? And I mean, that was about 5, 6 years ago, but still it's like, no, that needs to be the presentation, like from the CHW. So I love your idea, Michelle, of having a webinar like that. That's a fantastic idea.
Okay, well, maybe we can to our buddies over at ABAC and let's see how we can do this. Okay,
Right.
not how we can. I think we know how we can do it, but let's act on it. A lot of times we give a lot of, I gotta say, great lip service, but when it's time for the implementation, it looks different. So I'll reach out and speak to some of the folks I know at AVAC, and
Wonderful.
let's get this going. Thank you so
Yeah.
much. Yes.
Wonderful. Oh, Gabrielle, I do have to hop off as well,
Yeah.
but I want to really appreciate everybody who came and stayed on for this part of the conversation. Thank you so much, and thanks for sticking with us through the technical issues.
Okay. Have a great
Thank you,
day,
everyone.
everyone. Bye-bye.
The recording and slides will be made available online, and I will send out an email with the links to both. So keep an eye if that is something you are interested in.
Thank you so much for hosting this.
Thank
you for
you.
sticking
This
with
was
me.
wonderful.
Thank you so much.
Bye-bye.